related to addiction services. In 2024, there were 72,688 unique clients served with 181 staffers. In FY27, it's predicted that there will be 69,975 unique clients that will be served by 227 staff members. With the caseload decreasing, can you just go into a little bit of detail why you need additional people to handle less people?
Not sure those precise numbers. I might kick that over to Commissioner Miller.
So in 2024, you had 72,688 served by 181 people. In FY27, you're predicting 69,975 unique clients will be served by 227 staff members. So can we just get an explanation as to why with less clients, you have more staff working?
So some of what we've seen in terms of less individuals being served is because we have there are additional opportunities for individuals to receive treatment. We have our office-based addiction treatment programs so that individuals are able to go into to their practitioners, primary care practitioners and the like, and receive treatment for their substance use disorder and not have to go to the clinics. And so the numbers that you see that are represented there are the individuals who are served in licensed clinics. In addition to that, we've also had the opportunity to expand individuals who have lived experience, peers, in the community. They are working in treatment programs. We have other programs in outpatient settings, recovery centers, which are similar to like a drop-in center and the like. They're working in emergency rooms when someone who has presented who has had an opioid overdose in the emergency rooms. And the peer workforce has been really tremendous in helping to support individuals who have a substance use disorder. They, in sharing their stories, they're helping to engage individuals who may not have been interested in treatment. They are also staying with individuals as they are in treatment to help to support them as they are transitioning from one level of treatment to the next. And so I think with that workforce, it's helping people to stay in recovery longer. And so that, I think, is also helping to drive the reduction in the number of individuals who are being seen in treatment.
Right. So, but I'm saying you're seeing a reduction in individuals, which is great, but we're seeing a correlating increase in staff. So you're saying that there's a benefit to having more people on staff for this?
Can I just chime in here and just say this is in the context of tremendous progress on the overdose epidemic, right? We've talked about that in this body years running. We talked about it at the national level for years running. We're making progress. Overdose deaths in this state are down from a peak of 3,174 in 2022 down to 2,025 in 2024. There are more people alive today because of the efforts of those staff and the people that the programs serve than there were otherwise speaking. And when you can keep people alive, when you can expand the services that keep people alive.
So are you saying that people are alive because we're hiring more people?
I'm saying the variety of programs that we've had, including recovery services, including treatment programs, which are critical to the ongoing survival and treatment of people with addiction, has been successful. The strategy is working.
So there's a direct correlation.
Well, I can tell you that we have, I wasn't familiar with the stats that you just pulled out. What I did know is that we're having success with our current strategy here in the state of New Jersey.
Okay. Listen, if we're keeping people alive and we got to hire 46 more people, it's worth it, right? I mean, I'm just asking for that, so that's great. Next question for you. The state recently awarded Boston Consulting Group a $7.5 million contract for the One Big Beautiful Bill related to Medicaid implementation, right? On page D213 of your budget, there's an increase for administration of family care of $6 million, $5 million of which is for technical system development and compliance tracking, and 1 million will support unspecified consultant services. Is that 1 million part of the 7.5 million that went to Boston Consulting Group, or is that 1 million on top of the 7.5?
I will defer to one of my two colleagues down the aisle here on that second, on the specific, but I do want to start off by just saying, I want you to understand that 7.5 million in the context of what we opened the hearing with in terms of the incredible challenge before us, the incredible implementation challenge we have, and in particular, I would say the delta between 300,000 losing coverage and 150,000 losing coverage, which is what the Urban Institute projected our range. That's about, I'm rounding off here, so forgive me. That's 3 billion or 1.5 billion lost to the state of New Jersey, right? If we can get our systems working better, that is a $1.5 billion delta.
As somebody who was a consultant, I love what you're saying right now. So if they're listening, they're probably happy.
So yes, so I would say that 7.5 million in terms of thinking about the specialized knowledge we need to accelerate the progress we've had, the cross-state knowledge about what other states are doing right now, and the ability to talk to their other clients they're serving, hey, this working there, this working there. Of course we talk to our fellows, but somebody looking at that, and the temporary nature
No, I'm not saying
of
there's
this
not
push.
value in this. I'm just trying to understand.
I'll kick to them for that, but I want to be sure we understand that
No,
7.5
I
million.
get it.
And just with respect to that specific question, the $7.5 million contract that you're referring to was executed in the current state fiscal year, in state fiscal year 2026. The $1 million increase in the budget, that's for the overall state share of consulting dollars, which could include work similar to that, but also there's a range of other just ongoing Medicaid work that needs to continue to happen, and that's a range of different kinds of vendors that we work with there. So. It's the same pool of funding, but that $1 million is for a range of Medicaid operations supporting.
So that 1
HR.
million has nothing to do with the 7.5 that went to Boston Consulting.
The $7.5 million was in the current fiscal year. The $1 million is an increase for the upcoming fiscal year.
Okay. Commissioner, my last thing is the early and periodic screening, diagnostic, and treatment program. So in New Jersey, for medically fragile individuals who turn 21, we cut off their care when they hit 21, it goes from 24 hours a day to 16 hours, right? And if you're under 21, your level of care is determined based on need. But it seems to be arbitrarily, once you hit the age of 21, you go from 24 hours a day to 16 hours a day. New York doesn't do this. Pennsylvania doesn't do this. I've brought this up in the past. Is there a rationale as to why we do this for people at the age of 21?
I mean, I would say that we've done a full cross scan of all the other states, but there are certainly a number of states that do cap at 16 hours or other forms of cap and utilization management. This is an incredible challenge. I will just start out by saying, and I've talked to these families, I've met with these families, seeing what is possible and the lives that are possible.
What I don't understand is, my birthday is June 21st. On June 20th, I got 24 hours a day care. Nothing changed between June 20th and June 21st, except for this New Jersey specific rule. It's not federal. It's, New York doesn't have it. Pennsylvania doesn't have it. Why do we have it?
Yeah. I would say a couple of features. Number one, there are workforce challenges. I think even within the 16 hours, there are folks having trouble filling some of those PDN workforce slots and finding folks to hire there. There are challenges in terms of thinking about our broader, how do we get people out of institutions? And this is a movement that we're absolutely committed to. As we get more and more people out of institutions, as we are committed to, we are going to face this question more and more frequently in terms of thinking about what we want to do. I would also point.
This is private duty. This is
I
not,
understand, but I'm saying I'm acknowledging your challenge and your concern. As we are successful in hopefully getting more people out of institutions, we will face more of the concerns that you talked about. I acknowledge that. The last thing I'll just say, and I'll let you jump in. I do want to note that a lot of our home and community services are enabled in this state under what's called a Medicaid waiver. The only reason that matters is that the rules for how you determine what that waiver is allowed to do and what's called budget neutral, that's like basically says, what you do in the waiver has got to be what you would have spent otherwise without the waiver. That's a very one-sentence simplification of something that could be hundreds of pages. But that's a one-sentence summary. Those rules are changing. What that means to our ability to spend for this population in a post-HR 1 world is also going to change. I don't know what that means, but we're all looking at these factors. We want to get people out of institutions. That's increasing the need, right? To your point, I acknowledge your question. We also have a workforce challenge because we can't fill the slots that are in 16 hours right now, right? And
But
what
you
is the
get-
rules,
no, no,
federal rules
hold
going to
on.
happen?
I'm getting it
I understand.
24 hours a day.
Yep.
You can't then tell me when I turn 21, there's a workforce challenge.
I'm saying the number of people who are needing those adult services right now, a lot, I shouldn't say a lot, some of those people cannot fill the slots to fill even some of those 16 hours that are needed today. That's
Okay,
not
so
everybody.
let's say I'm getting 24 hours a
Yep.
day care, and I turn 21. Now I'm going to 18. I had 24-hour-a-day care, whether that was 2 people, 3 people, 12 people, whatever.
I'm talking across the state. You open it up
Yeah,
to 24
but-
hours, and the
But I'm
policy
saying
change
I
that
had
happens
it,
there. Yep,
and now I don't.
yep,
Just because the calendar changed.
yep, yep. I
So
acknowledge that.
here's the last question. This is the budget-related question specifically. When you go from this EPSDT,
Yeah.
now, good luck with that, to this MLTSS, right, the Managed Long-Term Services and Support Program, that 18 to 16 hours, what is the cost savings to the state?
I don't have the number for you. I mean, I will say, I also acknowledge that under 21 with regard to EPSDT is both a federal requirement as well as a program that's designed to address the very unique needs of kids who are under 21. And once you're out of that age range, those federal requirements don't apply. But B, we should find ways to take care of those children who are now adults. I totally acknowledge where you're coming from, Assemblyman.
Yeah, so if we could just get through the chair, just what that cost savings is to the state, I'd be curious to see what that is.
Understood.
Thank you. Appreciate it. Thank you, Madam Chair.